an OBGYN at the Health Partners Woodbury Clinic and Regents Hospital and serves as the Vice Chair for Health Partners Medical Group, OBGYN department. She is also the medical director for the OBGYN ultrasound department and is the medical co-chair of the Children's Hospital Initiative. Her passion is equitable and complete patient care for all patients. Dr. Domonique Jones is a certified nurse midwife with a doctorate in nursing. She received her nursing degree and Doctor of Nursing practice from the University of Minnesota. She is passionate about providing care that encourages meaningful engagement, respect, and self-advocacy. Dr. Jones currently works in full scope midwifery practice at Hennepin Healthcare. She is the vice president of the American College of Nurse Midwives Minnesota affiliate and a co-founder of the Indigenous and Midwives of Color Committee. She serves as the allied professional representative to Minnesota ACOG Advisory Council and is a member of the Maternal Mortality Review Committee. I'd like to introduce to you Rhonda Fellows, is a birth doula, childbirth educator, and doula trainer and mentor, a BIPOC birth worker, connector, and pelvic STEAM facilitator. She refers to herself as a lactation champion because of her passion for helping families feed their babies. Serving families in the Minneapolis and St. Paul area, Rhonda loves helping parents realize their strength and ability. It is her desire to help families understand their rights and options so they feel empowered to advocate for themselves. Before entering birth work, she spent 2 decades working to support healthy families. Her career has included working as an after-school program director, healthy relations, sexual health educator, community connector for an elementary school, homeless shelter, co-facilitator, and leading teen missions trips. I would like to welcome our speakers this afternoon. And I just have to apologize if I offended anyone by saying hallelujah on this screen. I work in many facets, but I just want to be a respecter of all. But I am very excited about this presentation, and I would like our presenters to begin. Thank you so much.
Good afternoon. Thank you so much to Wayside. Thank you, Nicole, for having all of us here. It certainly has been a privilege working on this presentation with Rhonda and Domonique, and so we're really excited to present to you. We have no disclosures to give you for this presentation. We have no conflict of interests. And for us, objective of this presentation, I think it's very timely because it is Black Maternal Health Week, which was deemed by the White House last year. Actually, it's like the anniversary of it is tomorrow. And so all of us are so committed and passionate about the care of Black and Brown women in a birthing space. So our objectives for this, number one, is to have a conversation. And so if you have questions in the chat, please feel free to chime in and interrupt. We want to talk. If you want to leave your questions for the end, that's absolutely okay. But we want to be able to have the participants define the differences between an obstetrician, a midwife, and a doula. We want to list the factors that influence the current state of maternal care, as well as identify how obstetricians, midwives, and doulas can work together to decrease maternal mortality and to create safer birthing environments for Black families. So I will start with, what is an obstetrician gynecologist or an OBGYN? Many of us assume that we know, but OBGYNs are doctors who have special training in the education in women and birthing people's healthcare throughout their entire reproductive life, before people decided to become pregnant, throughout and beyond their reproductive years. We have both surgical and medical training. Typically our training is a 4-year residency program after 4 years of medical school. Some OBGYNs have additional training focusing on certain aspects of women's healthcare. These include pelvic floor and reconstruction surgery, which focuses on the pelvic floor, urogynecology, incontinence issues, issues with pelvic pain. There are GYN oncologists that focus on cancers of the reproductive organs. There are infertility specialists that focus on the ability to get pregnant, as well as endocrine and hormonal imbalances and disorders that happen in the journey to pregnancy or before, as well as high-risk obstetric providers, our maternal fetal medicine doctors. Domonique, you're muted.
Sorry, folks, I couldn't get my mouse to work. So that brings us to what a midwife is. And a midwife is a licensed independent provider who cares for those individuals who are assigned female at birth and those who have internal reproductive organs. And so that means that a midwife can also care for a trans man or a non-binary individual needing either sexual, reproductive, or pregnancy-related care. Midwives provide care, not only during pregnancy, labor, and birth, which many people associate with midwifery care, and also the postpartum period, but certified nurse midwives and CMs plugged into later also provide general health services such as annual checkups, birth control, menopause care, and treatment for common infections and health problems. As I mentioned, there are many types of midwives. There's three main types. There's a certified nurse midwife, or CNM. There's also a certified midwife, and then there's a certified professional midwife. The certified nurse midwife is an individual with a degree in nursing and either a master's or a doctorate degree with a specialty in nurse midwifery. And the certified nurse midwife, a certified midwife receives the same kind of midwifery training, graduate level training as a certified nurse midwife, but without a nursing degree. They have the same licensing board. And then a certified professional midwife is an individual whose education and training path is slightly different than that of a certified nurse midwife or a certified midwife. But they do also have a licensing board, and they see mostly families in a community-based setting, so either birth centers or at home birth practices, whereas a certified nurse midwife or can also see people in any of those settings. And then a midwife views pregnancy and birth as a healthy life event. It's kind of this natural process that happens. With that, we do recognize that sometimes there are some high risk situations that arise, or there can be complications. And so as midwives, we work collaboratively with our OBGYN colleagues when there's things that have to do with an obstetric issue. And then we also partner with physicians and other advanced practice providers outside of obstetrics or outside of kind of the birthing world, depending on what the individual needs. And then the American College of Obstetricians and Gynecologists and the American College of Nurse Midwives share a professional statement advocating for collaboration between physicians and midwives, as well as other healthcare team members, to provide patients with improved outcomes and with improving satisfaction. And so the agreement recognizes that providers need to practice to the full extent of their education, training, and experience, and their licensure to be able to provide this well-rounded partnership between the healthcare team, helps birthing individuals meet their goals for labor and birth with minimal interventions. This includes recognizing that continuous one-to-one emotional support, such as that provided by a professional doula, really improves outcomes for laboring individuals. Midwives have an important role to play, but we partner with our physician colleagues and especially with our doula colleagues who do so much more than just labor support. And so I'll let Rhonda talk a little bit more about that.
Oh, thank you. So when people hear the word doula, they generally think about birth doulas, not realizing that there are many types of doulas, which I will only list a few, but there are a lot more than maybe even I realize. But as a birth doula, we are trained professionals who we provide continuous support. A big part of what we do is education in the prenatal period and even during the birthing time and in the postpartum period. But we have training in the basics of how to provide that type of care. But then many of us do continuing education throughout the year to be able to serve families and support them in ways more than just physical, emotional, and informational support during the birthing time. So this statement is from Doula International, which is only one of the many doula training organizations. And so I just wanted to make sure I say that it's the organization that's known the most, but there are plenty of grassroots trainings that are popping up throughout the country that are just as reputable or even more reputable. So I wanted to make that clear as well. So birth doulas, we meet with clients multiple times during pregnancy and oftentimes multiple times in the postpartum period. In addition to birth doulas, we have abortion doulas, postpartum doulas, fertility doulas, end-of-life doulas. There are adoption doulas and miscarriage doulas and sibling doulas who support the older children during the birthing time. And so the other one that sometimes you might hear is full spectrum doula. This is a doula generally who has training in abortion, birth, and postpartum, but they may also have training in other doula modalities as well. So this is an excerpt from an article through ACOG, and we're just going to read this together. So a skill set that includes a robust understanding of the patient's preferences, unconditional presence throughout labor, and unwavering allegiance to the patient and their birth experience. Learning to harness the role of a doula within the healthcare team will allow for healthcare delivery that is nuanced, efficient, and most importantly, patient-centered. So we just wanted to bring that out. Oftentimes people think, or maybe some experiences are that ACOG or obstetricians, physicians are not pro-doula, and we know that that does exist, but this is showing that ACOG, the governing body, is pro-doula and expresses that there needs to be a partnership between the medical staff and the hired professional support person. Also, you'll hear us go between words like mother and mom and client and patient and birthing person or birthing people or birthing families. And we just want to acknowledge that not everyone who births babies identifies as a woman.
Thank you, Rhonda. And so when we are talking about the disparities of care and the gap and of care among women of color, I think it's important for us to distinguish the difference between maternal morbidity versus maternal mortality. So maternal mortality refers to deaths due to pregnancy-related complications within the first year of giving birth, or at the time of death, someone is diagnosed with a pregnancy. We found that most pregnancy-related deaths are preventable. In every state, there is a maternal mortality review committee that reviews all the deaths of pregnant patients to determine whether these deaths are pregnancy-related or pregnancy-associated. And we found that although the numbers are small, I think any single death of a pregnant person or a birthing person is one too many. We found that there are disproportionate rates of Black and Brown women dying in and around pregnancy, as opposed to our non-Black and Brown cohorts. The most common causes of maternal mortality are cardiovascular effects, infectious and disease causes, as well as hemorrhage. We know that these causes of death are due to the increase of the severe maternal morbidity that is happening throughout the country, of which Domonique will talk about right now.
So maternal morbidity really refers to any physical or psychological illness resulting in disability related to the pregnancy, or actually related to the childbirth experience. And this morbidity creates a problem, an illness that has significant impact, mostly negative, on a person's quality of life. And so while some of these things that are listed on this slide can lead to maternal mortality as well, the disability and the impact on one's life at having, maybe high blood pressure that didn't exist before pregnancy, starting to have blood clots during pregnancy, that means now you're on different kinds of medication, having severe nausea or vomiting, it impacts so many aspects of your life outside of pregnancy. And some of these don't actually go away. And so it's recognizing that there are pregnancy, while it can be this great joyous time, there can be some lasting impacts that leave an individual with a decreased quality of life.
So what does ACOG say about maternal mortality and morbidity? And we see that the rates of maternal mortality and severe maternal morbidity increasing in the United States. And because we are seeing sicker birthing people, we see the exacerbations of these two. But what is the most concerning is that there are incredible gaps in terms of racial and ethnic disparities in these outcomes. And we see disparities in all aspects of medicine, not just in the obstetric world. And they are astounding. There is an ACOG committee opinion article that looks at gynecologic care and the most common conditions that we see in the GYN community. And every single one of them, there is a disparity and a gap of care between white women as well as people of color. And the basis of that is access to care due to systemic racism. And that's what we're seeing. A lot of people thought that, oh, it's genetics, it's that sort of thing, but it truly is bias and the differences of care secondary to that. We also are seeing that in a few weeks, this amazing series that's going on with Wayside will be talking about the postpartum period or the fourth trimester. And that is as equally, if not more important in terms of helping reduce these gaps of care. When we look at numbers of maternal mortality, the same percentage of women dying in and around the birthing time are there between day 45 and 365. And so that postpartum or the fourth trimester period is key. And it is recommended that a patient should be seen within the first 3 weeks of postpartum and continue through 12 weeks. And they should be seen as many times as they need to. Rhonda and we all were talking that, I mean, I wish that I could see everybody like every week for a variety of different reasons. And this is where legislature and lobbying comes into play, because in that postpartum period, yes, we are concerned about blood pressure and how much your bleeding is, but we are absolutely concerned about your mental and emotional health, because we know that is a huge change in life in that postpartum time. And when you couple sleep deprivation and life changes, the exacerbation of behavioral health disorders, the exacerbation of substance use disorder during that postpartum period is incredibly high. And so that is why that fourth trimester is so key in our evaluation and care of birthing people.
So as we look at statistics, which is just going to be a small part of this presentation, what I want you to think about as we look at these US statistics is it race or racism? Because that's the question we need to decide. But we actually already know the answer. We know the answer. The CDC knows the answer. Institutions know the answer. The media knows the answer. But how do we move past knowing the answer to actually making the change and to be consistent with that? And the other thing is, we cannot get rid of hospital birth. You know, it'd be great if it was just easy. Oh, don't birth in the hospital. Just get rid of all the hospitals. But actually, some people medically need to birth in the hospital. Some people medically need a surgical birth. And so if we can't, and some people also desire to be in a hospital setting and have pain medicine, right? And so we have to somehow as a country tear down the racist structure that built obstetrics and create and build an equitable infrastructure. Really, that's where the shift happens. In the meantime, right? In the meantime, before that actually happens, and we have discussions like this, and then at our local levels, we need to make changes. So how do low-risk birthing people in hospital not have similar statistics to low-risk birthing people out of hospital? That's another big question that we really need to tackle, because if it's truly about race, then low-risk people of color birthing out of the hospital would have similar statistics than low-risk birthing people in the hospital. And from any research we can find, even though there's not really good studies, they don't have the same outcomes. So Those are things to think in mind as you have these conversations with people. So we're gonna really open up our conversation between the three of us and hopefully answer some questions starting at this point. So in Minnesota, 20 to 30 women died a year related to pregnancy complications. US born African American, so US born, really important. Black women are 2.8 times more likely to die than white women. American Indian women are 7.8 times more likely to die than white women. US born African American Black women had 11% of the births, and they also made up 15% of the maternal deaths. American Indian women had only 2% of the births, but made up 12% of the maternal deaths. And also, as we go through, if there are any statistics, you can see where we receive that information at the bottom of the slide. So I want to open this up to Domonique and Corinne to talk a little bit about this.
So when we were preparing this presentation and trying to figure out, how do we partner together, some of it is so much bigger than the immediate, the physicians in the room and the doulas in the room and the midwives in the room. And some of it is definitely bigger than what we do on an individual level. And some of what we need to do when it comes to our policymakers and legislation and public health work. But when you look at these statistics and you look at the fact that Black women and Native women have these quite alarming rates of death compared to our counterparts, especially here, in Minnesota, but all over this country, right? We have our Indigenous sisters who are dying. We have Black women whose ancestors were brought here forcibly who are dying. And it comes back a lot to how this country was founded. It was very much so of taking advantage of those who the colonizers felt were kind of beneath them. And those policies and those practices, even though this country is trying to work through this and recognizing these issues, there's still this embedded racism that is really impacting these generations of women who are having babies. One of the things that I thought was quite appalling is that this country, our Indigenous sisters, this is their country. They've been here for, longer than anyone else. And they have such a small percentage of the birth rate, and they're dying at such larger numbers. And so we really are doing a disservice by not working well together and really working on public health policy and working on supporting these women to have birth and really looking at what is it about racism that is being so detrimental to this population as a whole.
Also, as there are these policy committees and groups of people working towards fixing this issue, we also have to look at who's on these committees and who's making the decisions. Do we have people of color, people from the communities that are being killed in the medical system? Do we have community workers like doulas and out-of-hospital midwives and in-hospital providers as well, working with the policymakers and the decision makers? Because if we don't even work together in that realm, we're not really going to get to where we need to get to.
And I think this slide speaks to Rhonda's statement, is it race or racism? And so I take issue personally, this is just my own little mini soapbox, I take issue with birth weight being a measure of maternal health, but that's what we have at this juncture in time. And so if we look at this, the middle section, when you look at birth weights and first generation African immigrants versus white women, as white women are the standard of measurements. The birth weights are exactly the same, but the longer these African immigrants, the longer we stay in this country, the longer we are subjected to the chronic stressors of structural racism. The longer that I keep seeing somebody that looks like my uncle and my brother be killed, the longer that I keep getting followed in the store, the longer I keep experiencing micro and macro aggression, those rates change because those physiological effects of stressors are real. They've been studied, it's absolutely real. And so you see in terms of race, that if it was just race, that number shouldn't change from the time that we were brought here to now. But we see that over time, that graph shifts to the left. So those weights are getting smaller. And so the answer is there. It is not race. It is absolutely racism. And in terms of some of the statistics that we talked about, one of the things in these committees, people like to put it on, oh, it's just socioeconomics. It's just socioeconomics, and that people that don't have money, that lower class, though that's the reason why these birth weights, and that's why that women are dying more. But if you look at that, me as a college and above educated woman have still a 2.5 times likely chance of dying than a less than high school educated Black white woman, And so when my friends who were my classmates are calling me and say, what do I say to not let them kill me when I'm in birth? What do I say to not let them kill me when I'm having a baby? That's not socioeconomics. That's not race either. So that's all I have to say about this.
Mm-hmm. Mm-hmm.
This here is just a kind of graphic representation to show some of these statistics in a way that is more visual. Sometimes visualizing these numbers helps you. You can see that overall, the maternal death rate in the US, while it's not great, which we'll show on another slide compared to other developed countries, you're like, well, I wouldn't want anyone to die because of pregnancy, but we know that it's a thing. We know that it happens, and it doesn't seem that significant. But when you start to really look, when you break it up, this is why it's so important to break it up. Who is dying? Who's actually dying? And you see here that Black birthing individuals are dying at such an alarming rate compared to their white counterparts. Mm-hmm. And as Corinne mentioned, it doesn't matter what your education level is for a Black woman. It doesn't matter how educated you are. It actually is not protected. And so it really gets us thinking about, we need to change. There's a bigger issue, and we need to work on bringing that down. And so when you come to this next slide here that shows the maternal death rate of other developed countries, and you see how high the US is there, you start to wonder, well, what's going on? And one of the biggest things is that many of these other countries, like you might see Switzerland there and the Netherlands, they still have a pretty homogeneous population, right? They do have more immigrants from different places, but for the most part, a lot of those people who live there, the population is similar in race, similar to identity. They have this shared identity. And you come to the US and there's so many different identities, and there's so many different races, and there's such a different cultural there's so many different cultural pieces that are missing in some of these other places. And so you start to see where that gap can come in. There's definitely much more to do with maternal death in the US with racism than maybe in some of these other places. And as I talked about on that previous slide about breaking up who's dying, when you do that in these other countries too, you do see that the women there who are either Indigenous or brown or Black are making up a high portion of that number as well.
So how did we get here? And I'm going to be real short because I can talk about this topic for hours. I just want to say, if I'm ever in a birth room with you and you're a provider, please don't say this man's name in my presence. Every time a provider says this man's name to me, it's a slap in my face. I am Black, and my ancestors were abused by this man and people like him. So let's just start there. Okay. So, and also, can we stop calling him the father of gynecology? Really? We know he and his partners, his people, had a big part to do with obstetrics as we know it, which is how we got here. Because the racism that was happening then that gave them the permission to abuse vilely Black bodies to discover what we do now, that type of racism is still here now. So even though slavery is technically over, and even though the racism then is still now, and it is why we are dying. And so Many things are created, positioning, I just lost my word, positioning, different apparatus, also procedures. We know that he had a hand in creating them, as we know them. However, we can switch our vocabulary, but also this truth needs to be taught. So if you're on here and you teach as a professor, as a preceptor, please make sure you're teaching the truth of this. And if you need more information, because we can't educate you, here are a few places to start. Both of these books, especially Medical Bondage. Medical Bondage is specifically about Sims and I forget the French man's name, and the women that were forced to participate. And so we see the forced experimentation I was just mentioning, but also there were Black women who were being experimented on, were also forced to be nurses and help to find and found these things. And so in Montgomery, it was on the other slide, but in Montgomery, there are statues that were just recently erected to give credit to these women who were forced to be a part of this vile treatment or experimentation. So also, as we move through, the timeline of years, we see the Black women who were brought over on the boat during slavery. They were people who had skills, just as the men as well. But we think about, oh, they were on the plantation, so then the white people taught them how to be midwives. They did not. Let's stop that bad teaching as well. Nope, they came with talents and gifts. They knew herbs, they knew the plants, they knew medical procedures, the things they were already doing over there. They knew when they were going to allow a baby to be born in slavery. They knew when they were going to abort that pregnancy because they weren't bringing another baby in at this point. And so these midwives, we eventually call them the grand or granny midwives. And then at some point, when the white man decided, I got obstetrics, we're going to get this going in the country, then they had to convince everyone who was loving and believing in these Black midwives that these Black midwives were no longer safe, no longer clean. But I have the thing for you. Come on over to this hospital we've created. Okay, so now we have obstetrics led by white men. We are no longer using the old Black women. And we have to create something to replace them, which is the creation of the certified nurse midwife profession. And if you were to watch the documentary on YouTube, it's 55 minutes, take the hour to watch it. It's called All My Babies, and it follows one of the grand midwives. So it's not Hollywood, it's actual footage of following her, but they also show footage of how the certified nurse midwife profession became and how it took over and how they dehumanized the grand midwives in the process. And again, see how it's passing through the years. We can also look at forced wet nursing. So these enslaved Black women were forced to nurse, to breastfeed the white babies. And so then it's like, you're doing all this work, you're breastfeeding them, and then you come home tired and you got kids to feed as well. Or maybe they're with you and you have your kids with you to feed. But we see how that and the sexualization of the Black body during slavery, all of that still exists now because we have extreme sexualization of our bodies. We have a lot of people who believe that, well, you shouldn't be breastfeeding your little boys because that's sexual assault. We have the creation of artificial baby milk. Yep, I don't say formula, I say artificial baby milk, because the formula that was used to create the artificial baby milk was to convince the Black people not to breastfeed their babies and use this product that the white man created. And so you can see how racism is interwoven through all of that and still exists today. We still, in our Black population, have such low rates of people who believe that nursing your baby from your body is safe, it's clean, and as long as your body is producing properly, that it is better for your baby's body because the body knows how to break it down better than artificial baby milk. I'm talking fast because we got to move on, but I want to make sure we say some of this because it's part of the problem we have with our people dying. So please research the Fultz quadruplets. I can teach a whole class just on that family. So research them to understand how the white man targeted this Black family who had quadruplets in order to convince the Black Americans to stop breastfeeding and to start using artificial baby milk.
So how do we partner? I think that all of us are just going to talk. We're going to talk together. And I think it's so important to know where we came from, because like Rhonda said, everything that went on with enslaved women, the basis of it is still present today, which is why you see 3 Black women before you that represent single-digit percentage numbers of the respective fields that we are in. The recruitment and retention of qualified applicants, the funding that is required to go to school and that sort of thing. It is not there for everybody. And in terms of birthing individuals, I think that we've all talked. I was like, I think that everybody should have a doula. And I believe that doulas are not the right of the privilege, but is the right of someone that is having a birthing experience. And I think that they should be paid, they should be compensated, they should be recognized. And partnering all of us together, we all have a role. We all have a place in providing a safe birthing experience for women of color. And a lot of this just starts with communication. I don't have so much pride to recognize, like, I am not needed in this room. Congratulations, ma'am. Have a great day. Rhonda and Domonique have it under control. I'm just going to quietly leave. And that is the best experience to have, because it is just operating as a full team. I don't like when I go in the room and introduce myself and the doula or support, they're like, oh, no one's ever acknowledged me. No one's ever said, hi, who are you? You know, and that's a terrible thing to do, recognizing that we are all here together, that our goal is a happy, safe mom and a happy, safe baby. And, you know, if we get that in mind, I think a lot of stuff would be a lot easier. And all of the things here on this slide.
And we have 2 slides that kind of talk about how we partner. And there's a lot of different things on here. As Corinne was mentioning, just about open communication, about really letting that idea of ego go as providers, and knowing, you know, where we are at for helping the birthing person, and how we can really support them. But it goes bigger too, right? About how do we get obstetricians and midwives to be on the same page and treat each other as equals? How do we get obstetricians and midwives to be on the same page and treat doulas as equals? We all come to this with an expertise that's a little bit different and services families in different ways. And so, you know, there are some programs out there that are starting to have residents working closely with midwifery students during their training. Some residents, when they go to the hospitals, are learning with midwives who are already there. These practices helps each to really understand, you know, what is this person's role? What is their expertise? You know, what are they bringing to the table that I don't know yet? Some of this comes from, you know, I would like to say misunderstandings, right? About what each person brings to the table. What are they there to help do? What are their unique, you know, areas of expertise and knowledge that they're going to help this person? And so, you know, I think it's beneficial to have, you know, doulas having opportunities to come in and do teaching for residents and do teaching for obstetricians and teaching for midwives about the things that they do and how they help families and how they are important for great birth outcomes, and having opportunities for all of us different providers to be working together even before we get in front of families, so that we can go in there as a united front, bringing all of our different experiences and bringing in this information to really help families to welcome their, you know, their new member.
What would it look like for hospitals to allow a couple doulas to shadow someone? And I know families would have to agree to that. But I'm trying to get on Domonique and Corinne's coattails in some of their prenatal visits and in some births with them. And on the other side of the curtain with Corinne in the OR, you know, like how do we build those relationships, like individually, but collectively as providers and practitioners, to say, you know what you do is important. Let's learn from each other. Let's, how do we do that, right? It can be easier in an out of hospital setting to maybe forge some of those, but I don't think it's impossible to forge relationships within the hospital as well. And part of, one of you mentioned the word ego, like sometimes the provider having an ego, but we also can talk about doulas having egos. You know, we can talk about doulas who felt mistreated being at a birth. We can talk about providers and hospital staff and birth center staff and home birth staff who may have felt mistreated by doulas. You know, so we can say both things from both sides, and oh, I had bad taste with these couple people, so I'm not going to participate with anyone from that group. But if we want to partner to reduce these statistics and to support and serve families better, then at some point we have to figure out, how do we partner? And that starts with inside, you know, that starts as an individual. And one thing I'm really passionate about, and I want to keep yelling it, is if you are not doing the work individually, not my job told me to do this racism training, like you actually doing work on yourself, stop touching Black bodies. Just stop. Like you should say, I can only serve white families in the hospital. Great. I'm talking about providers. I'm talking about doulas. I'm talking about nurses and other staff. Do the work or step back. Like I'm on white people shift this week because I haven't done any work. And I know that's hard and nobody wants to hear that and nobody wants to do that and no one wants to say that. But really, you shouldn't be touching Black bodies if you can't do the work internally, because that's part of partnering. Like, I'm going to do my work and then come together and work with the team.
We had legislation and advocacy on the prior slide. And I think what's important when we kind of look at that, it's at a patient level, but it's also, you know, ACOG and ACNM, we are organizations, or I say we, but I'm not we, but they're organizations that have funds and they have lobbyists and they have all of this information. And, you know, there's been some work to bring in the certified midwife, and ACOG supports that, and ACNM definitely supports that. And why I bring that up is because part of this is we need more education. We need more providers. As Corinne mentioned, you know, there are a small number of Black physicians. There are a small number of midwives who look like me. And this is especially true, I think, for physicians in obstetrics. You will run into more Black physicians in other fields, but obstetrics tends to be paid less in some of those other places. And people are like, I work real hard and I need to pay off all those student loans. And so it's about finding these other avenues to bring in more people, not just who look like me, but more of our Native providers. You know, we need more diversity as a whole. We need more diverse doulas. We need more diverse nurses so that there's opportunity to be challenges in the way that I want, but to see face to face, like, oh, this is a person that has been marginalized, but this is a person sitting in front of me. Is that mom that I've decided that because of her name, or because when I see her come up here, that I automatically assume that she maybe has a drug addiction, or I automatically assume these things. We need to make education more affordable. And so the certified nurse midwife, while I love being a certified nurse midwife, I think this is a great thing. If I had had a different opportunity to be a certified midwife and not have to get a nursing degree, I might have done that. It would have been more cost effective, but I made the choice and I jumped at it, and I've not regretted that decision, but that student loan payment haunts me all the time. Mm-hmm. And so there are many people who are not taking these leaps to become physicians, who are not taking these leaps to become midwives because of a cost. And so the certified midwife takes out that nursing education that needs to happen, also providing a really lovely, wonderful, well-rounded place. And so that's where some of that legislation comes into, right? How do we change some of these barriers that prevent more people coming to the table, more people that we get to partner with, who get to bring their ideas of improving outcomes, improving the lives and well-being of not only these women or birthing people, but really all of us as a whole.
I even think about in the process of birthing, laboring, you have the different hospital staff or birthing location staff, and then whatever support people they brought, plus if they also hired a doula, we're all in a room, but are we working together? So even down to like thinking about that specifically, am I saying as a doula to the nurse, do you have ideas for what we can do next? Here are some of my ideas. When the provider comes in, are we having that conversation about ideas? Is a provider saying, once they come in and say whatever they need to say and do what they need to do, hey, doula, I see you do this. tell me more about that, or show me what you think you want to do next. And how do we work as a team? Because when there's tension between us, we can slow down a labor. Let's just be honest. We, as the support birth team, we can slow a labor down. So how do we work together to not hinder, or these are ways we can work together to not hinder someone's labor?
I think that also when we are working together, we are a trusted unit, and that trust begins not just at that labor, but it begins in that prenatal time period. So I always encourage patients that have doulas, I'm like, please bring your doula to your prenatal visit. Like, let's all get on the same page early on, not when things are critical, when there's an emergent situation and, you know, we don't have the luxury of time to kind of, you know, navigate where our roles are. And I really, I see the best partnerships that I've seen have been like my first time meeting the doula, or my first time seeing the doula isn't like when she's pushing, or it's we've gone through everything together. Everybody is on the same page. Everybody is operating as a unit, and that's where strength comes.
Yeah. Nicole, have you seen questions that we haven't answered?
There are a couple of questions. And so one was they wanted you to please state again the name of the videos, as well as the reference of the family, the quadruplets. So if you could share that.
Yep, a Fultz quadruplets, Fultz, right here on the screen. And then All My Babies is the name of the documentary on YouTube.
And are they both on YouTube?
So researching the Fultz quadruplets, you can just Google it and tons of things are going to pop up. There is a book that will pop up. I haven't read it, but there is some racism involved in that because supposedly a white woman decided to write a book without talking to the Black family. So I'm not promoting that book, but of course we got to find racism and all at every turn in a story like that. But there is a book, but there's plenty of things. I will say I've been researching. I just did a training yesterday, lactation for birth workers. And in my research for that, I learned that of the 4 sisters, first of all, the white doctor named them, but you can learn more about that. But of the 4 sisters, 3 of them died from cancer by 55, and the 4th one died of the same cancer in her 70s. And you could just look into that. I won't go there.
Okay. And there was another question, and I'm scrolling back, so please be patient with me. I believe it was, because I don't want to miss it, I think I can recall it, was that I think it was a child health worker was asking about how to collaborate and how to basically in making phone calls to invite moms to classes that they're not getting a very good response. And I'm going to find the exact question of what other ways can they do partner in order to invite families to classes around birthing. And I'm going to go back through.
Yeah, I think part of that starts as a person who does childbirth education or teaches that. I do think part of that starts in clinic visits with providers. Like we need providers to talk about doulas, to even if they don't know a lot of doulas, give some names. Oh, I had a couple births with these people. If providers will start writing down doulas' names after births so that they can talk to their clients about the doulas they had a good experience with. Also, we need providers to say, you should take childbirth education classes. And here are a couple doulas who teach it, or here's an organization that teaches it. Because a lot of us doulas do teach childbirth education classes.
The other point that she stressed, I found the exact question, is how do you invite them and the importance of sharing information, but also without scaring them. They don't want to scare them away, but they want to empower them with information. So if you could just even expound a little bit more on what that could look like.
I think that being open with patients is really, really key. I think that the facts and you being aware of what the statistics are in terms of disparities of care says a lot about you as a provider, you providing care for a birthing person. So I think that withholding it is far scarier than saying it. And so I think that it's important just to say, these are the statistics that are out there. among Black and brown women. These are the gaps in care. This is what it looks like. What I'm going to do, though, is try to do everything that I can to prevent that from happening. I'm going to educate myself. I'm going to be your advocate. I'm going to tell you how to be your own advocate. I'm going to provide evidence-based care. I'm going to do all of these things. And I think that in itself, even those two lines just establishes a significant amount of trust, because then if I was a patient, I'd be like, oh, okay, well, she sees me. I'm seen, you know. I'm not just somebody. I am seen as a Black woman, because I identify as a woman, and she understands that my journey is different from maybe my white colleague, or if I'm a Native woman, that my journey is different than my white colleague.
Thank you. Also, there's a question that says, in the hospital, and this was going back to Rhonda when you were talking, and actually all of you were talking about partnering. Sherry's asking, in the hospital, can we use a team birth model where all providers are in the room? Do you know about any model like that? Or are you guys creating one from this? Talk today.
Domonique, do you have a thought? You had a look on your face.
Oh, well, as Corinne said earlier, right? It's not that we don't want all providers maybe in the room, but do you actually need us all in the room? And the answer to that is no, you don't actually need all of us in the room. But, you know, I know that at my organization, the midwives, our service is separate than the physician service. We are truly two separate entities, but we do work together. We, you know, we really work to talk to each other and share what's going on. And a patient recently sent in like a thank you note or whatever. And it just said they ended up needing to have some care transferred, and they talked about how seamless that seemed to be between the midwifery service and the OB service, and how they really felt like that showed that there was mutual respect between those two groups. And so there is a way, I suppose, to have kind of a team model where not everyone necessarily needs to be present. And so anytime I do an initial visit or a visit with someone who's interested in receiving midwifery services with Hennepin, I talk about the collaboration with my colleagues who are not midwives. I talk about how they're part of this team. I talk about how if there's something that comes up, our goal is to keep them safe, and that they might do a consult visit with my colleague, or those colleagues might visit them at some point during their hospital stay, to really keep that door open. And if there's things happening in their labor or that happened prenatally where we've talked about maybe there could be some greater interventions, or maybe our OB service will want to come see them, I try to make a habit of bringing in our attending and the senior resident to at least meet them at some point before maybe things are getting a little bit more urgent and can't quite, process what's happening.
And then I feel like it was a suggestion with that question was even having the doula's name or the supportive persons in the room also listed on the whiteboards. That suggestion as well. The next question says, how can we envision birth and or postpartum doulas collaborating with physicians and midwives in early home visits the first 4 weeks post-birth? And that's from Haley Rogers.
So this is where things get a little bit more tricky. And this goes back to, legislation and things like that. Right now, for any hospital-based physician, physicians are hospital-based, any hospital-based midwife, part of the way that funding and payment happens, that midwife cannot do a home visit for you. It's not something that's part of the medical model as it stands. Where I know that in community-based birth, at birth centers, someone from that birth center is coming to see you within a couple of days to 24 hours or so after birth. And so, it's definitely more difficult when we want people to come in for that postpartum visit so that we can check in, but we're also asking this mother or birthing person to leave their nest that they feel secure and safe with their baby to come see me. And they're like, well, you know what? I don't think I need to come see you. And so I think it's nice for us as providers to know that that patient had a doula. Did we get to meet the doula at a visit prenatally or something like that? Did we get to meet that doula in the birthing room? And knowing that that doula is continuing to see families. We at the hospital I work, we have a doula program where we offer on-call doulas at no charge to patients if they come in and don't have a support person, if they come in and they don't have a doula. Maybe they do have a support person, but they need a professional. And while that's a great experience, it's a very, time limited right here. And they're not getting that emotional support from the doula prenatally and also postnatally. And so I talk about our doula program, but I also talk to people about the benefits of hiring a doula that's just for them, because that person will be able to spend more time with them. And so we do also try to send out from like our medical side, we try to send out nurses to check in with families. Sometimes we try to get them connected to a family prenatally and then postnatal. So that's kind of how physicians or midwives from the hospital setting do a home visit. We don't really do it, but we try to get nurses who are connected to go out and do that. And then hopefully patients have doulas that we've gotten to meet and who we know are also seeing that individual. And so sometimes the patient will fill out something for HIPAA, allowing their doula to contact us to say, hey, the patient is at home, they seem to be doing well, or hey, I saw so-and-so today, I encourage them to make an appointment. Can you have someone make sure that they made an appointment because they don't seem to be doing well, or whatever that might be. And that can be really beneficial for a laboring and birthing person.
I'm going to suspend
that HIPAA form you just mentioned. Be great if all the providers listening would bring that up to their patients who have doulas and prenatal visits.
And I'm going to suspend the questions. I see you have the slide up, and I know you had maybe one or two more. We are at 1:00, but I want to make sure that you're able to share references and finish up.
I don't need to say anything about this. It was up long enough for people to see it. You can Google the birthplace lab.
Okay. Do you want to show the references, though? I think that's really, in resources, that's really powerful.
Yeah, so if Dr. Corinne or Dr. Domonique want to say anything else, as people see these resources and references, go ahead.
I really want to say thank you for everyone who decided to join our talk today. I hope that there's some information from today's talk that you found useful and will somehow be implemented into how you are taking care of families, or will maybe help you to think about ways that your organization can take care of families, and also help light a fire under you to talk to some legislation and find that person who's your representative and be like, hey, did you know that we don't pay for this? Or hey, did you know that doulas are so important, they don't get enough money to be part of the team? Just different things like that. So thank you so much for coming on board.
Thank you so much for your time. Thank you so much for inviting us. We're honored to be here. We're honored to participate in this work. If you have any additional questions for any of us, please let us know. We had a fun time. I mean, I can't speak for y'all, but I had a fun time. But we all had a great time being here to talk about things that we love.
Yes, and maybe before we after we end the recording, but before we shut down the Zoom, Nicole,
yes,
we can get a copy of the chat, copy and paste it, so that maybe we can send out an email with some answers to some questions we couldn't get to.
Okay. And I'll be honest, I don't know how to get the transcription of the chat.
I'll get it. If you
awesome.
Just after you stop the recording, I'll get it.
Awesome. And so there are still a lot of people on, a few people left. I want to say thank you to all three of you. It was wonderful. Rhonda Fellows, Dr. Corinne Brown Robinson, Dr. Domonique Jones. I appreciate you so much. There's so much that's going on in my mind about what you shared today. And I think about restorative practices, right? And really about working with one another in that room is about understanding harm can occur. Or if I work with you before and there may have been a way in serving a patient that didn't go the best, conversations and understanding and communication, collaborating in advance and working those things out are huge to our community in terms of serving us, right? Because restorative practice is about building relationships. In Indigenous communities, this is what we do. We are always looking ways to support one another, restoration, renewal, and honoring who we are in the community. And so I thank each of you for your wonderful talk today about partnering to decrease maternal mortality, and definitely addressing many of the inequities, but just providing an understanding and that the goal is working together. So thank you very much for everyone who attended. There were a few questions. As Rhonda mentioned, we'll copy that chat, and I have access to your emails, and therefore I will be sharing that with the presenters, and there will be follow-up. And please email me if you think that this wasn't enough time. Did we need more time? Was there more to discuss and have from these wonderful professionals that we have here with the diverse expertise? Okay, great. I already see, yes, we need more time. So please feel free. We are building a community network here, learning from one another. So please email me any suggestions and how we can move forward as we have 2 more cohorts. Thank you, everyone. Have a great afternoon.
Thank you.